I'm here presenting a diffuse large B-cell lymphoma in the head and neck and how to manage it. This is a 59-year-old male presenting with nasopharyngeal diffuse large B-cell lymphoma with bilateral cervical lymphadenopathies. The patient to receive 3 cycles of R-CHOP to be followed with consolidation radiation therapy. The PET scan after the 3 cycles of R-CHOP showed a complete remission since the Duvel score was 2 out of 5. These are contouring tips. The CTV in red shows how we chase the areas in the fat between the muscles. And when you compare to the pre-chemotherapy, as you can see, the mass has slimmed compared to the pre-chemotherapy. So therefore, when we are creating the CTV, it will not be as big, at least cross-sectionally, as it was pre-chemo. Also, other things to notice is that when you expand the CTV next to the critical organ like the submandibular gland here, you try to shy away from it. And when you use IMRT specifically, you try to make the edge kind of flat, because when the dose is deposited there with the small irregularities that sometimes we don't mean to put it there, eventually you will deposit a dose in those submandibular glands or in the parotid gland like you see right there. And this is consistent with every time we put the CTV. As you can see, you remove the bone, the muscles from there, same thing in here, and you definitely remove the air from the CTV because that's where we think the site of the original disease was. This is another contouring tip which has to do with the arms on the PET scan that are above the head in most of the cases, and if you end up simulating the patient with the arms down. As you can see, the very same area would show different amount of the bone and the shoulders. Although fusion is very helpful to plan these cases, but we have to be aware that with the arms up in the PET scan versus the arms down in the simulation, there is a major difference in the anatomic location of these lymph nodes. So sometimes a visual eyeballing back and forth might be more helpful than actually the fusion. These are coronal views just to reiterate what we talked about. As you can see here, the mass pre-chemotherapy was big and wide, but also was displacing the muscle outside versus when you end up making the CTV here, as you can see, it will be very thin and just chasing the fat where the nodes sat in between the muscles. The IMRT, also another thing another technique that we should not just use blindly. We can interfere with some forward thinking whenever we plan these cases, in a sense that we shouldn't necessarily use an equidistant angles when we use the IMRT. That's why we prefer IMRT in general over VMAT, since you can control the angles that you are using. So in this particular case, you are interested in avoiding the submandibular glands and the parotid glands. And the way you want to avoid them is not to use the same numbers that we use for head and neck, because in head and neck cancers, we use doses that are sometimes 3 times or 3.5 times higher than the doses that we give in lymphoma. Therefore, we cannot use the same mean dose. For example, a mean dose to the parotid of 26 gray would not make sense for lymphoma. Rather, you can at least divide it by 1/3 and aim for less than 10 gray of a mean dose. Quite often we ask for less than 5 gray of a mean dose. And as you can see here, if you assign it a less than 5 gray, you can majority of the time achieve it. We always have to remember that these patients live for a long time. Therefore, maintaining an excellent quality of life for them is very important. The same thing as you can see here for the submandibular glands. And what helped us to do so is, as I said, to be careful and thoughtful whenever you put the CTV, to shy away from including the parotid or the submandibular gland in your CTV volume. This is the DBH, and in all honesty, DBH is important, but what's more important is to see where the dose has been deposited. But nevertheless, you can really achieve great numbers if you are thoughtful on how to on how to contour these patients. And as you can see here, all salivary glands achieved sort of more than acceptable doses. So then the take-home message when treating head and neck lymphoma is that for cases of lymphoma involving the head and neck that achieve a complete response to systemic therapy, ISRT can be applied to deliver consolidation radiation therapy. The nodal regression in the transverse plane permits sparing of normal tissues, as we explained. And while traditional dose constraints that are often used in cases of head and neck cancer are often easily achievable in lymphoma cases with a prescription doses of 30 gray, significantly lower doses to normal tissues should be pursued to minimize the long-term toxicity and maintain an excellent quality of life.